Welcome and thank you for joining us today. I'm Lori Buer, and I'm on the board for the National Meningitis Association. We are live streaming today on NMA's Facebook page, and our president, Lynn Bozoff, wanted to be here tonight, but she is ill and couldn't travel to New York this weekend. So she's asked fellow board member Leslie and I to pick up the baton, which we're willing to do, but you'll have to forgive me if I look down at my paperwork more than I look at all of you. So Lynn is planning to watch the feed and follow everything on social media. So in the spirit of sharing, please post about this event to your social media accounts using the hashtag #YesVax and the hashtag #PreventMeningitis. NMA is proud to host today's discussion about communicating vaccine science and vaccine mandates, two extremely important topics to me and to all of our NMA advocates. In 2003, our youngest son, Carl, contracted meningococcal disease. He's a survivor, thankfully. He was 14 years old at the time he became ill. He did suffer amputations and multiple skin grafts, but he's living a successful life today and is also a member of TEAM and a strong advocate for NMA. Since 2002, NMA has worked with hundreds of advocates who have also experienced the devastating consequences of this disease. Together, we've helped raise awareness of meningococcal disease and pushed for both nationwide recommendations and state-based vaccine mandates. We know how important both efforts are. We need parents and teens to be aware of the risks of meningococcal disease and to understand that the vaccines work and are safe. But that's just part one. We need policymakers to use all their tools to encourage vaccination, and mandates are the best tool in the toolbox. Today, 81% of young adults in the United States have received the primary dose of the MACWY vaccine by age 16. Protecting 4 out of 5 teens is not good enough, though. The other 20% also deserve vaccine protection. But then we have other challenges. All these teens need a second dose at age 16, but only 33% are getting that recommended booster. While we don't have exact figures yet, we believe that even fewer teens receive the newer MenB vaccine. This is a vaccine that teens need to be protected against the serogroup of meningococcal disease that is our most frequent cause of college outbreaks. This means many of our children are vulnerable right before they go off to college, a time when they are at heightened risk of getting meningococcal disease. And it's important to note, it's not just young adults on college campuses who are at risk, but all young adults of college age. There are threats to the progress we've made. Last year, a documentary by the discredited researcher Andrew Wakefield reinvigorated anti-vacciners. Robert Kennedy Jr., a vaccine skeptic who unfortunately has built-in name recognition, was given a national platform when he and our new president appeared to be teaming up to assess vaccine safety, something that has already been amazingly well studied and needs no new assessments. With that, let me introduce the terrific panel we have with us today, who will touch on all of these issues. Their bios are in the handout you received when you came in, so I'll be brief in my introduction. Our moderator, Arthur Allen, is an author and e-health editor of POLITICO. In 2008, he released Vaccine, the Controversial Story of Medicine's Greatest Lifesaver. In the book, he covered not only the history of vaccines, but the history of public resistance to vaccination. Dr. Paul Lee is at the other end. He is the director of the International Adoption Program and Pediatric Travel Center at Winthrop University Hospital in Minola, New York, where he is also an attending physician in the Division of Pediatric Infectious Diseases. He is a clinical assistant professor of pediatrics at SUNY, Stony Brook. What's SUNY? All I know is University of Washington. Go Dogs. Okay, State University of New York. Excuse me. And Dr. Paul Offit, grinning down there, is director of the Vaccine Education Center at the Children's Hospital of Philadelphia. He is co-inventor of a rotavirus vaccine and a best-selling author. He has written several books about vaccines, the anti-vaccine movement, and junk science. And Dorit Reiss is professor of law at the University of California, Hastings College of Law. She specializes in legal issues related to vaccines, including exemption laws and funding the costs of disease outbreaks linked to non-vaccination. Alison Singer is president of the Autism Science Foundation and a lifelong advocate for raising awareness about autism spectrum disorders. She is the mother of a child with autism and has a brother with autism. And Dr. William Schaffner is professor of preventative medicine and infectious diseases at Vanderbilt University School of Medicine and the medical director of the National Foundation for Infectious Diseases. He is particularly skilled at making public health science understandable to the average person, so he is called on often by the media. He treats every media request as a teaching opportunity and is a wonderful advocate and educator about vaccines. Dr. Amy Middleman is associate professor of pediatrics and chief of the section of adolescent medicine at the University of Oklahoma Health Sciences Center. She has been a practitioner and a clinical investigator in adolescent medicine since 1990. A major area of focus is vaccines. And Dr. Jason Schwartz is an assistant professor in the Department of Health Policy and Management at the Yale School of Public Health. He has written widely on vaccines and vaccination programs, decision-making in public health policy, and the structure and function of scientific expert advice to government. So our goal today is to address critical issues that hinder childhood vaccine success in the U.S. Following a brief opening talk by our moderator, Arthur Allen, to define the problem, Arthur will pose a series of questions to the panelists. After the panelists' questions and answers, we have yet set aside 30 minutes for audience questions and discussion and encourage you to participate. And now, Arthur Allen.
Thank you, Laura. Laura, right? Laurie. Thank you, and I'm really happy to be here and with this wonderful panel that you're all lucky enough to be privileged enough to be hearing today. So, as everyone here believes, and most of you I hope also, vaccines are a very valuable part of medicine, but unfortunately they've worked so well that most parents, and there may be some exceptions here, I think Laurie is one of them, are luckily don't have the experience with the vaccine preventable diseases. And so they're unaware of the good that they're doing. They're doing such a good job that people don't appreciate them. In 2014, the CDC estimated that vaccines have prevented more than 21 million deaths, 21 million hospitalizations, and more than 700,000 deaths in the past 20 years alone. So despite what they've done for public health, vaccine science and mandates periodically come under fire, and they have rather consistently for the past decade or so, a situation that hasn't been helped by certain celebrities, including our current president and at least two other Republican candidates during the recent campaign, spread alarming and inaccurate information about vaccine safety. But anti-vaccine movements are as old as vaccines themselves. This has to do with the fact that primarily that pediatric vaccines are given to healthy children. They're given in a period of life when many things are likely to happen subsequently to a child, because many children develop different kinds of illnesses. And vaccines often get blamed, and people are afraid to stick their child with or give their child something, and they don't know what's going to happen later. So the current anti-vaccine sort of surge really began when Andrew Wakefield, a British gastroenterologist, published a since discredited and retracted study purporting to link measles vaccine to autism. As it's always done, the anti-vaccine movement has pushed for the elimination of vaccine mandates or for the weakening of existing mandates by expanding exemptions for parents and their children. I was told a few days ago by Dan Salmon, a Johns Hopkins University researcher who follows these things closely, that the overall percentage of American parents who oppose vaccination completely is still only about 1 in 200. But in any case, every generation of parents has questions about vaccines, and the proliferation of this really bad information on the internet and other online forums means that parents are perhaps more likely than at any time in history to get in the grip of misinformation. In some surveys, up to 3 in 4 parents have expressed concerns about vaccination, whether it be vaccines generally, vaccine ingredients, the belief in a link to autism, or the feeling that there are too many vaccines given. These concerns reflect a new healthcare landscape. There's been a transition from an era in which parents and everyone just trusted the doctor would always make the right decision, to the current environment in which parents are really, and everyone is really encouraged to be more active in their care, and this goes to some degree also to pediatric care. This can be a good thing. It's good to engage parents and other patients. But some parents put too much emphasis on sort of their personal values or ideas that they've picked up along the way at the expense of science. So to use this scientific term, there's always been right and left-wing anti-vaccine crazies. The lefty anti-vaxxers tend to think that vaccines are unnatural, contaminated with poisons, pushed by greedy pharmaceutical companies. And on the right, it's all about the government not having the right to tell you what to do with your children. Then there's been concern about some of the cells from aborted fetuses that were used to create the original rubella vaccine and other vaccines. The Pope has said that that's okay. And then there's the idea of moral hazard, which supposedly argues against having your children vaccinated against any disease that's sexually transmitted, because it means that your child, thus protected, will be more likely to do something that's immoral. Despite the small percentage of people who flat out refuse to vaccinate in this country, diseases like whooping cough in particular have flourished in small communities where there is a large belief system that opposes vaccination. An example might be sort of a liberal kind of crunchy-feely community in Boulder, Colorado, but it's also true in southern Utah, certain communities where there have been measles outbreaks because of opposition to vaccination. But most Americans in both political parties continue to understand the value of vaccines. But at the present time, partly because of the president's position and these discussions, there's some evidence of a gap between what Democrats and Republicans trust, the degree to which they trust vaccine science, just as there is over climate science. So being anti-vaccine, I would say, is fairly uncool if you're a Democrat now. But the health freedom rhetoric that's frequently the parlance of Republicans when they discuss the question of mandatory insurance is also used by some vaccine skeptics when they talk about mandatory vaccination. So we really have to avoid vaccine science becoming a partisan issue like climate change, and that's tough. So I'm going to let our panelists take it away on how we can avoid this. Let's see. There's such a range of talent here. It's hard to know who to ask first. But first of all, I'd like to maybe we could just go down partway down the row until I jump in again. I guess on what people think is the best way to quell parental concerns about vaccination as doctors. Let's the doctors take this on. So Paul, first Paul Lee.
Right. In terms of the parents, I think it's this is very loud. The relationship you have with them and the trust factor. They have to believe that you believe and that you're really doing it in their child's best interest.
Amy?
Yeah, I agree with that, and I usually try to link with them from the get-go. I think it's also really important for parents to understand. I think there's an idea that deciding not to vaccinate is delaying a decision. It's actually making a decision. It is an active decision that can have consequences that you cannot take back. And that's something that I think it's really important for parents to understand. And I also think it's really important for parents to understand where the safety information that they're getting in the media. There are experts here who know a lot about the VAERS system and the passive surveillance versus hypothesis-driven research in order to describe safety issues. But most of what parents hear is unsubstantiated data from the VAERS system, which is a great system that serves a really important purpose.
Just not the way people often use it.
But people misinterpret it. And I think it's really important that providers also help parents understand the information that they're receiving and why it may not be necessarily.
But when you get down to the level of a parent bringing up VAERS, isn't it already kind of times up for the pediatric visit?
VAERS is.
Right.
Oh,
Okay. I'll explain. Well, VAERS is Paul, Paul Offit, why don't you explain what VAERS is?
So VAERS is the Vaccine Adverse Events Reporting System. It was the product of the National Childhood Vaccine Injury Act in 1986. It was put in place in 1988. Basically, anybody who has, who believes that a side effect is a consequence of vaccines can then report to the system. Anyone, a parent, doctor, personal injury lawyer, anyone. And it's a very noisy system, which is to say, got the vaccine, now have a problem. So you really can't in any way tell from the VAERS system whether the vaccine actually caused the problem. At its best, you can argue it's a hypothesis generating a mechanism, but it's certainly not a hypothesis testing mechanism. And I think in many ways, VAERS is misused. Especially by the anti-vaccine people who will say, look, here's the HPV vaccine. There are 80,000 adverse events that have been reported, when in fact, none of them may have had anything to do with the vaccine.
Right. Well, what's the, Dr. Schaffner, maybe you would like to take this one on. Do you think that physicians should talk to parents who should admit, or that pediatricians should admit parents who don't want to vaccinate children to their practices? Let's talk about that. Let's start off on that.
I'm laughing because I'm the internist in the crowd.
Oh, I'm sorry.
So telling the pediatricians what to do.
Yeah, tell them anyway.
I think that pediatricians and my colleagues can chime in, at least in my neck of the woods down in Nashville, have done a variety of things. There are the pediatricians who take them as they come and deal with all the questions that come up, and by the end of the day, they're exhausted frequently because they're having to give vaccines 101 every time they see a new mom, because the concerns and the issues are really very, very common. Even though the mom may not be anti-vaccine, the mom is frequently vaccine curious, vaccine not knowledgeable, I don't want to say ignorant, and looking for information, and they've heard all of these things. There are some of my colleagues in pediatrics, a group practice, for example, who, when new moms come in with their babies, say, here's the deal. We vaccinate all of our children according to the recommendations and the schedule of the CDC and the American Academy of Pediatrics. You're in or out. And that makes it a lot easier for them, and they have an initial screening. But I think there are an awful lot of pediatricians who are educating daily and constantly, and I remind them that the Latin word that's the root of the word doctor is docere, to teach.
Yeah, I think at the very least, it's an impossible question. I mean, it's lose-lose. Right. In many ways, if you don't see that patient anymore, then who knows where that child goes? I mean, ultimately, you're the child's advocate, and then you've lost any chance then to convince them. On the other hand, if you continue to see that patient, you have to have some respect for your waiting room, where there's going to be potentially more and more people who aren't vaccinated and sitting right next to people who can't be vaccinated. I think at the very least, what I try and talk to our, sort of young medical students about is be passionate, which, at least, let me love your child. Don't put me in a position where I'm being asked to practice substandard care, where I'm being asked to send these children out into a world that's becoming progressively more dangerous, more measles, more mumps, more pertussis. Please don't put me in that position. So at least you show the parent that you too are a parent, that you too care about their child and love their child. And at least if you're going to lose, go down swinging. Don't just sort of stand back and say that at some level it's okay, which we do. I think, when you just continue to see patients who aren't vaccinated, at some level you are tacitly agreeing that it's okay, an okay thing to do.
Right, and I think the other dilemma is that for some of these pediatricians, it's like, well, the parent is trusting me on one thing, but is not trusting me on other issues. How can you have a relationship where there's like 50% trust, 70% trust, 80% trust? Because then they're going to start quibbling about every one of your decisions. Like, I want to put your child on Tylenol. I like Motrin instead. So, why are they speaking? you know, it's like they're relying on you for your medical knowledge, but then they're challenging it at the same time. So I think for many pediatricians, that's a tough thing. And you worry about what kind of ongoing relationship you can have. And if they don't trust you in that, something that you feel, as Paul said, so passionate about, then are they going to trust you in other things when their child gets very ill or something else happens?
The other thing I make clear, though, with my patients is that we can agree to disagree today, but you have to understand that I feel very strongly about this. This is important for your child's health. I will bring this up every single visit. You have to understand, I will bring this up every single visit. We'll talk about it. I will be respectful, but you have to understand that the data show that this is what's best for your child, and that's my job. That's my job. I'll do it every day of the week.
Do you think that pediatricians are sort of taught, or physicians in general have the sort of the right training to talk about these issues? I mean, should there be like a small mini curriculum developed about like how to deal with a parent who doesn't want to
I often
vaccinate?
joke that they all need to be members of the debate club in college, because you really need to. I mean, because I think that we tend to have this very dry approach, where these are the facts, this is the science, and as I think you know, Paula said earlier, you have to be passionate about it, because if I just start reciting facts and you know, it doesn't register at all. It's like when your parents lecture you about things and they just recite facts. When you hear a story, which is what a lot of the celebrities do, they have this very, you know, engaging and enticing story. That's what grabs people's attention, and if you don't have that story, you don't get the, you know, you don't get the parents' buy-in.
I think if anything, in many ways, medical students are taught in a way better than I was taught. I mean, they're taught to be much more open-minded to all sort of different attitudes and beliefs and cultural differences, which is great to a point. But this is that point. And so they are trained to sort of, I think in some ways, to stand back. Also remember, most young doctors not only don't see these diseases today, they didn't grow up with these diseases.
Right,
For them,
right.
too, it's also a matter of faith. So they become much less passionate advocates.
Do you think that there's a benefit to sort of shaming? I guess, can doctors shame or not, maybe in a subtle way, just like, you don't want to vaccinate. Okay. I mean, I don't know, just,
Well, you know,
because how do these ideas shift? I mean, if a parent reads enough of these studies, it's like nobody has time enough to like refute them one right after another. Go ahead, Jason.
This is where the action is these days. So what the Pauls have been talking about in terms of how do we optimize the response in the doctor's office to understand how physicians can best deploy knowledge and passion and dispel facts and show compassion, all those sorts of things. There's randomized work happening because we know that strong recommendation from a physician who has a long-standing relationship of trust will do more than any CDC information campaign or any press release. And that's figuring out how to optimize those encounters in a scientific way. It seems to be the frontier in responding to vaccine hesitancy.
And now I'm forgetting the details of this, but there was a study that came out a few years ago that was when you talk to parents who already have, review that for me. What was the outcome? It was like Dr. Schaffner.
Brendan Nyhan.
Jason?
Sure. So this was a political scientist from Dartmouth, looked at ways to try and say what kind of messaging strategies can be used to change attitudes regarding intent to vaccinate. So this was a sort of a controlled kind of study, and looking at showing narratives of vaccine-preventable diseases and the tragedies they cause, showing images, trying to show the facts and the scientific evidence. And the lesson from that one was not an encouraging story, that basically none of them worked, that they all sort of raised alarms in the self-reported intent to vaccinate story. So that wasn't encouraging, but we have a range of that's not the end of the story, it's the first part of the story, but it shows that we need to figure out what can work best.
First, I'm going to let Dr. Schaffner.
Well, psychologists tell us that if you have a firm belief in something, and then you encounter facts that are directly contrary to that, the normal human reaction is to double down in your belief, and works in politics too. And I think so. We have to expect that the initial response is for parents to get defensive and to even insist even more strongly about what they've said. So I think I don't think shaming works, but I think a warm embrace, a sense of trying to say that I'm with you and trying to indicate to the parents that what you're really doing is presenting the best of science, as Paul would say, but also kind of an emotional, as Paul was saying, to kind of embrace the parent and try to get them in to you.
Dorit?
I just wanted to kind of echo what you're saying by pointing out that the Meehan study wasn't actually in the context of a relationship, and that's one of the differences. Information provided by someone who isn't in a relationship with a parent is very different from a parent going to a doctor with which they already have a trusting relationship.
That's a great point. I mean, a lot of people didn't like that study because they didn't think it sort of mimicked events in the real world.
Okay.
And I think it was a limitation.
There's actually a recent study from Noel Brewer about HPV vaccine and how to approach discussing that with parents. Now, they had some intervention practices where doctors just said, you're going to get your Tdap, your HPV, and your MCV4. And then they had practices where you're going to get these vaccines. Let's talk about these vaccines. Do you have any questions about HPV? Do you have any questions about... And they called that the conversation group, and the intervention group was the announcement group. Just announce you're going to get the vaccines. The intervention practices had immunization rates for HPV vaccine 5.4% higher than the control groups. Now, that may not sound like a lot, but from a public health perspective, it's a lot. It's not as much as we need. So there are some pros and cons with that, but I think it's important to really remember, again, that most parents actually are just looking for that little extra bit of information. They're not against the vaccine necessarily. They're asking for just a bit more.
But if you say, we're going to talk about vaccines, then aren't there a certain number of parents who say, what is their problem with that?
Right, exactly, and that's why the announcement method is so good, because it's saying, this is what is to be done. This is the data. This is what should be done.
Oh, that one gets better.
That one got
that's
better.
okay,
Yes.
right.
We actually did a study in Houston where we asked parents how important they thought, they rated on a visual scale, 0 to 10, how important do you think these vaccines are for your child's health? And they rated it, every parent rated each vaccine, including HPV, influenza, the ones that have low immunization rates, at about a 9.3, okay, out of 10. Then we asked the providers what they thought the parents thought about the importance of those vaccines. And for HPV, the number was 5.2, 5.7. 5.2 or 5.7, I'm not sure which one. But you can see there's a complete misconception on the part of the providers that parents are much more worried and distressed about these vaccines than in fact the parents are reporting they are.
There's a name for that. It's called provider hesitancy.
Yes.
And it's a major issue today. The National Foundation for Infectious Diseases has done a similar study asking patients and providers about vaccine recommendations. And of course, all the providers said, oh, sure, we always give vaccine recommendations. 88% of them or thereabouts. When you ask the patients, they said, what recommendation? It's, if you say, you ought to think about getting your flu shot. That's a recommendation? Is that the way we recommend treatment for high blood pressure or diabetes? It's time for your annual flu shot. And then only respond if there is an objection and say, what? You're not? I'm vaccinated. Everybody in my family is vaccinated. The whole practice is vaccinated. We want to make sure everyone in our practice is protected. Roll up your sleeve, Alison.
There you go. Yeah, right.
And that's advocacy.
Yeah,
You can't be wishy-washy.
right. Alison, what's your experience been? There was a lot of concern in the community of people who have kids with autism about vaccines. Are you seeing that change at all? And is it still the same kind of divisiveness there, or are there, I don't know, is it an issue that's brought up a lot now still?
It's still brought up a lot, unfortunately. I think many of us thought that once we conducted the studies to look at whether vaccines caused autism, that we would sort of come to the end of my speaking on vaccine panels. When you look at this question, it's a question that science can answer, and science has answered it. We've looked at whether MMR kids who get MMR have a higher rate of autism. We've looked at kids who get vaccines with various amounts of thimerosal or no thimerosal have a higher rate of autism. We've looked at whether kids who have no vaccines, some vaccines, or vaccines according to the CDC schedule have a different rate of autism. And in all of these studies, the data are very clear and unambiguous. It's not like we have half of the study saying one thing and half of the study saying the other thing, and so more studies need to be done. At this point, no more studies need to be done. The data are clear, and yet we are still in a situation where many parents are concerned about vaccines causing autism. And I think it's because, I'm going to quote Paul's book, it's once you put that scary idea into someone's head, it's very hard to get that scary idea out. So we then turned our attention in another direction. We said, well, parents are saying you can't tell me vaccines don't cause autism until you can tell me what does cause autism. So we've been investing for the last 10, 15 years in autism research to look at what is causing autism, and we've made remarkable progress. We can now identify the genes that cause autism in about 40% of children with autism. We've learned through imaging studies that autism's origin is prenatal. We see differences in brain structure in fetuses in the second trimester. That is well before babies have had exposure to vaccines. We know that there are certain risk factors for autism, like advanced maternal age, advanced paternal age. Certain environmental exposures are likely to increase the rate of autism. So we are now focused on that strategy, which is trying to answer the question of what does cause autism.
I'm curious, is it, any of you know whether there's been any serious effort to enlist, advertising industry in figuring out the best ways to communicate about vaccine safety? I mean, they're so good at selling stuff, right? I mean, doesn't that ever occur to anybody?
Who's going to be paying for that?
The National Foundation of Infectious Disease, I heard was.
We'd love it.
Right. Well, not but I mean, isn't there? They do some free advertising. Well, one other question I had about this topic is there a way? I mean, unfortunately, we're now having quite a bit of whooping cough, and also there's now measles outbreaks in the U.S. again. Is there a way of transmitting the horror of that to your patients? I mean, rather to the parents when they're talking about it. I mean, measles is just, people don't realize what a major, threat and also big, pain in the what it is.
I think the answer to the question, what's the best way to convince a parent to get a vaccine, is to have an outbreak. I mean, nothing educates like the virus, and that's what happened in Southern California, right? You had this group of parents who had chosen not to vaccinate their children. There was an article that was published by Gary Baum claiming that he had visited these elementary schools in these upper middle class areas in Southern California, like the Marina Del Rey and Santa Monica, and saw that the immunization rates were less than 50%, less than South Sudan, as he said in that article. Published it in my favorite medical journal, The Hollywood Reporter. And then 3 months later, as he predicted, there was an outbreak in Southern California among these groups, which then spread to 25 states, involved about 190 people, spread up into 2 Canadian provinces. What happened to those parents who had chosen not to vaccinate? They couldn't wait to get vaccinated. I mean, they were going to these sort of generally anti-vaccine pediatricians, like Jay Gordon or Bob Sears, and they were getting vaccinated. Measles scared them, and so that's it. Fear sells. Sadly, people are compelled much more by fear than reason.
Cool.
I want to address this as someone who's active on social media and to point out that the measles outbreak didn't, I assume it made a difference to doctors in the practice, but it made a dramatic difference in the discussions on social media and on newspaper articles. If before there were, so the anti-vaccine people in response to articles online are extremely passionate. They may be wrong in their beliefs, but they believe them very strongly. If in the past we had a whole group of anti-vaccine activists and a small number of people responding to them, in the past couple of years, since the measles outbreak, there's been a lot of new faces, a lot of people that just are people from the community that feel that they need to speak up. The outbreak made a difference in the discussion.
Is that, and what's the end result of that? I mean, is it, so does that, do you think that, does anybody done any like studies on, it's a very difficult thing I would think to study, but just how memes like are stopped in their tracks or are, you know, by counter memes or, you know?
Dorit would be the one to answer that question.
Yeah,
So,
yeah.
Reiss from California did, I don't know, I wouldn't call it a study, but an analysis of comments on Twitter, and looked at the effect of anti-vaccine comments and saw that they had a lot of activity but very little reach during the outbreak. I don't know of any more serious studies of that. If there are, I'd love to know of them. But in California, we had the practical effect of passing SB 277.
Right, so talk about that a little bit for this audience.
So SB 277 was a California statute that removed the personal belief exemption. Before it, it was very easy to opt out of a vaccine in California. Yes, okay. Sorry. You basically had to sign a form before the change in the law. The change in the law meant that only people with medical exemption could opt out of vaccines, although it's implemented gradually. Right now, it's implemented to kindergartner and 7th grade, and it will gradually apply to other years.
Well, I'm curious about that. I want to follow up on that. But so now we're talk a little bit about mandates, vaccine mandates. They've been, you know, a strategy since the late 19th century to require vaccination, starting with smallpox, and then actually, and these are state laws, although there's federal law that applies to how they can be structured. In the 80s and 90s, when we had our last very serious measles epidemics, the states also cracked down, I guess, for the last time. And now it's become an issue. There's, how many states, Dorit, now are considering laws to either strengthen or weaken exemptions?
There are 130 plus vaccine-related bills, but not all of them are about exemptions.
Okay, right. So these mandates work very well in a general way. Hepatitis B immunization rates in Florida increased from 13 to 71% following implementation of a middle school mandate there. And, you know, they explain why there are diseases that are still pretty common in Europe, such as measles, that were virtually eliminated in the US and still really only occur in batches when they're reintroduced by travelers coming from Europe or Africa. So the limit of mandates is, and it's also, the benefit of mandates is that it helps provide this herd immunity, which means that depending on the disease, having a certain amount of people around you who are protected from getting it, either because they've had the disease or they've been immunized against it, makes it that much less likely that you're going to get it if you're in some way vulnerable to it. Either you haven't been vaccinated or you can't be, or your vaccination has waned. So, for example, the pneumococcal vaccine, when it was introduced, about 20 years ago, the pediatric...
The conjugate pneumococcal
The conjugate,
vaccine,
yeah.
2000.
2000, so yeah, about almost 20 years ago. I think the biggest health impact it had was on the elderly, I believe, because
Well, so the so-called
in terms of-
7-valent vaccine
Right.
had a major impact on children, but it also did have an impact on those who weren't vaccinated.
who weren't
So there
vaccinated,
was
right. So anyway, so just for the audience here, the mandates have always had some exemptions, such as a medical exemption if for some medical reason you can't be vaccinated, and then there are religious or philosophical exemptions. All states have medical exemptions. Religious exemptions are allowed almost everywhere with a few exceptions, and then 20 states currently, I think, grant philosophical or exemptions for, you know, philosophical or other belief exemptions. So I first let's talk about the impact of these different varying exemptions on the spread of disease. Who wants to take that on? The impact of, I mean, there is a direct relation, I believe, between the strictness of the exemption law and the levels of vaccine preventable diseases in those states.
Yeah,
Correct?
I mean, so you know, studies by Dan Salmon and others have shown that there's a direct relationship between those states that have looser laws, those people groups where people are choosing not to vaccinate actually are at increased risk of disease. Thus, once again, showing that the germ theory is not a theory; it's a fact. People, if you prevent germs, then they don't spread. So, yeah, I mean, it's exactly what you would expect. See, also, and Jason should really comment on this because he's done most of the work on this, but I sort of object to the terms in some ways. I mean, philosophical exemption of phyla, love, sophos, wisdom. Where's the wisdom that it's better not to get a vaccine than get one? And also religious exemption actually bothers me even more. I mean, religion teaches you to care about your children, care about your family, care about your community. I mean, the notion that you're putting children in harm's way unnecessarily is a profoundly unreligious thing to do. So I sort of object to the terms. I call it what it is. I don't really, I've been scared about vaccines. I've read a lot of scary things on the internet. I don't really see these Jenny McCarthy's, my guru exemption. Call it that.
Well, but there are also religious groups that don't believe in it.
Well, it's Christian Science.
Yeah,
I mean,
Christian Science and a few sects here and there.
Yeah.
Rosicrucians, I think.
So Jason should
and even the Christian Scientists, because I brought them up on a podcast or an NPR broadcast once, and even sort of Christian Science doesn't have the sort of hierarchical structure of the Catholic Church or elsewhere, but even their sort of central office said, actually, we're not adamantly opposed to it. It's a decision that can be left to individual adherence. But these questions about non-medical exemptions reflect this sort of fragile compromise or truce, political compromise more than an ethical or moral one about how far do we want to go in requiring vaccines without non-medical opt-outs. And it's a question, it's a political question, it's a tactical question as well in terms of whether or not exemptions as a safety valve, as a pressure release valve, may serve the quote-unquote greater good of vaccination programs to give the folks who are most adamantly opposed an option while still accruing most of the benefits of the requirements themselves.
I mean, I guess, Paul, what's the evidence on this? I mean, what's the evidence that there are states that do have very, very strict laws? Has there been any backlash anywhere because of the strictness of the law?
Oh, well, Jason can answer that too. Jason knows that.
Yeah, so we've seen from California in 1 year, and Dorit has been watching this firsthand, encouraging data that suggests the concern that many, myself included, had that there would be a backlash to those ironclad policies that could do more harm than good, and enforcement would be overwhelmed, and public health departments and schools wouldn't be able to keep up with opposition. That hasn't happened, at least through this 1 year, but it remains to be seen. That's an empirical question, but the California signal seems to be a good one so far, right?
So it depends what you mean by backlash. There's been an effort to do a referendum to recall the proposal of the law, and there have been 4 lawsuits so far, and at least one more that is trying to be brought forth. So if by backlash you mean people angry with the law and trying to undo it, we definitely have seen that. If by backlash you mean a mass immigration out of the state and a mass rebellion, we haven't seen that.
Or out of the schools.
And the rates look
Or
better.
out of the school. The rates are better, yes.
Right, and granted, there are 2 states that don't have any exemptions at all. Although it's West Virginia and I believe Mississippi.
Yep.
And
Yeah.
California.
And California.
Oh, and now California. So, and again, I haven't heard any major backlash coming out of the South.
Right.
And then those have been longstanding for years.
But I also want to say this is a very political situation. This really isn't about science, and I think parents don't necessarily always understand that. So a lot of parents will say to me when I'm talking to them about vaccines, well, that one's not required. And I say, no, all of the vaccines are routinely recommended by the Centers for Disease Control and Prevention. All of them are routinely recommended. The requirement is a state political situation. Yeah. And I think parents really get confused. This is absolutely recommended for your child. End of discussion, really.
Bill, I think had.
Well, perhaps I could put this in a little bit of context. Your original question is, do mandates work? It all started with measles and the prevention of measles, and just to make sure that everybody in the audience understands and remembers, measles was a common disease. Virtually every child acquired it, and it was also terribly serious. Back before we had measles vaccine in the United States, that had a smaller population then than it does now, each year 400 to 500 children died of measles and its complications. So when measles vaccine came on the scene, every pediatrician in the country, every family doctor wanted to immunize. Now think about this. This was before there were no shots, no school laws. If every pediatrician and every family doctor is working hard to vaccinate their patients, think about what proportion of patients, children, were actually vaccinated. With a huge effort in combination with public health, you could strain to get to 70%.
Right.
That's a sobering fact, demonstrated time after time, and 70 or just 72% maybe was the absolute top you could do. That meant a third or more of children went unvaccinated, and what further happened is, because now you had a lot of children vaccinated, the interval between outbreaks of measles lengthened, which meant that actually when you got your measles, you were older, and if you're older when you got your measles, you're more likely to have complications. So
Therefore
it was
making
then
it-
decided to have no shots, no school, and that virtually eliminated measles. And to make it larger, the implementation of those sorts of programs, those comprehensive programs, means, for example, that the entire Western Hemisphere, from the Inuit up in Alaska to the tip of Terra del Fuego, has now interrupted the transmission of measles. There's no endemic measles. There's no locally acquired measles in the entire Western Hemisphere, except when it's imported and spreads among children who have been withheld from immunization. And there's actually one country that has more of those than any other. It's not Ecuador, it's not Paraguay, it's not Mexico, it's the US of A. We put the rest of the hemisphere at threat.
You know, it's interesting. So, for example, right now in Hennepin County, Minnesota, you have an outbreak of measles among the Somali population. It started when a 30-month-old traveled, who was U.S.-born Somali descent, travels to Kenya, gets measles, comes back, and now it's a relatively unvaccinated community because there was fears that the measles-containing vaccine caused autism. So what went from, you know, like 94% immunization rates in 2004 is now down to like 40%. So now the Minnesota Department of Health is running circles, you know, around themselves, trying to get everybody immunized. At the same time, the anti-vaccine forces are sort of moving in, telling people that it is their, here are your options not to vaccinate. In this state, you have both a philosophical and religious exemption. It is remarkable to me that parents actually can choose not to vaccinate in that setting. I mean, the reason that they're choosing not to do it is a false one. I mean, the measles-containing vaccine doesn't cause autism. And so is it your right as a U.S. citizen to catch and transmit a potentially fatal infection? I don't think it should be in that situation. I think that those parents should be made to vaccinate their children. I mean, I
Well,
know
what's the law on that? I mean, when you're in the middle of an epidemic, does that change
Talk about 1991.
what a parent's responsibility is? I mean,
Well, yes, and so in Philadelphia, for example, in Philadelphia,
Well,
in
yeah.
1991, there was a measles epidemic that centered on two fundamentalist churches that
Right.
didn't believe in vaccination or health care or medical care. They believed in praying to
Right.
God to cure their children, which didn't seem to work very well because there were about 1,400 cases of measles and 9 deaths in our city. That was in a several-month period, right? 1,400 cases and 9 deaths in one city in a several-month period. We went through a series of laws, eventually ending up to the point where we had, for the first time to my knowledge in the United States, compulsory vaccination. Those parents were forced to vaccinate their
Right,
children.
right.
And the ACLU, which is perfectly willing to represent unconscionable causes, were not willing to represent these parents. Even what they were doing was legal. I mean, there was a religious exemption that was on the books in our state for 10 years. What they were doing was perfectly legal, but they didn't represent it because they felt that it violated the health. That you shouldn't, that basically, that while you're allowed to martyr yourself to your religion, they didn't believe that you should be allowed to martyr your child
Right.
to your religion.
So there's more than one body of law at work here. Law is about categorizing things. Exemption laws stand, and they stood in Philadelphia during the outbreak. They were not suspended. A parent could still send a child to school unvaccinated during the outbreak. That law was still in the books. It's still in the books in Minnesota. There's nothing stopping those children from attending school. That's what exemptions do. The second question is, how much can the law intervene to protect the child's welfare? And the answer is that we respect parental rights. We see parents as the first line of defense of the child, but up to a limit. if, as in this case, a parent's action can directly put a child at risk and put others at risk, the courts do have the ability to intervene and say enough. Now, would they do it? That's a little bit tricky. We don't do it often and we don't do it easily because, first of all, because we do respect parental rights. We put them on a very high pedestal maybe. Some scholars say we put them on a too high pedestal. One scholar describes this as we treat children as quasi-property. But there are limits to that. And second, because there are concerns about all kinds of practical issues. Sending basically police to enforce forced vaccination can, in some communities, backfire. It certainly isn't easy on anyone. So it's not something done easily. It can be done, but it's just not done easily.
Well, I guess under the current situation, we could also just deport them and the measles.
These are legal refugees and children citizens. This is not an
I
immigrant issue.
didn't actually mean that.
And I was actually
No,
thinking,
I do want to raise this because this has come up in discussions where people say this is a problem of immigrants. This is not a problem of immigrants. These people came in with high rates of MMR
About the
vaccination.
Somalis,
Yes,
Yeah,
I'm talking about the
right.
Somalis in Minnesota. They came in with high vaccination rates. They came in as legal refugees. The children were born here. These are American citizen children. And the vaccination rate dropped because a group of anti-vaccine activists, mostly American, one, at least formerly British, came and talked to them. This is a problem we create.
Right.
It's not an immigrant problem.
Right.
It's an American-created
And
problem.
in Somalia, they have a lot of measles because they have a terrible, terrible, terrible war, which is really total disorganization is one of the only places causes for lots of measles epidemics these days. Well, let's talk about, can you talk about California a little bit? Is there any other state that's trying to follow their example at present?
There are several. So Oklahoma has tried, and Amy can talk about this maybe more. Several years in a row, Oklahoma has tried to change their immunization law. And several other states have tried to do away with exemption. It's just very, very hard to do. Remember, generally passing a law in the US is not easy intentionally, in any state, on anything. It's a long process and it's hard to pass. It's much easier to stop a law. In this case, we had battles in Texas. We had battles in going the other way in West Virginia, where someone wanted to add a religious exemption. We had battles in Oklahoma. We had battles in Colorado. There are several states where there were battles around exemption law in the past years, and maybe other people can add from their state.
Well, I know that in some states, some of the laws seem incredibly superfluous and intentionally obstructive. So in Oklahoma, there were also some there was a proposed law that was luckily vetoed at with the governor that would have required providers to give parents like a 36-page appendix.
Initially, it was supposed to give parents a 36-page appendix.
With any vaccine.
It was narrowed down to give parents a 4-page list of ingredients. And these are laws brought forward under the rubric of informed consent. But imagine this. You're sitting in the doctor's office and you get a list of ingredients. How much does that promote your understanding of what's going on and what the treatment is? And does that help you inform yourself?
Yeah, and it's ridiculous.
It helps you misinform yourself.
Right, because you have actually a higher risk of severe adverse events taking amoxicillin than you do for any vaccine. And people ask for amoxicillin. That's the irony here.
You should look at all the chemicals that are in coffee, honestly.
Arthur, what else we're seeing in not every state, eliminating non-medical exemptions will be politically viable or feasible, but there is that second branch of research that Dan Salmon, the name we've mentioned, Sodomer and others have noted that not all exemption policies are alike. And in some states it's as easy as signing a form. The state where I live, Connecticut, you get the form, you load up the website, you sign your kid's name, and voila, you have a religious exemption. And there's plenty of research that shows that incremental administrative burdens, getting the form notarized, writing the statement, submitting it in person, renewing it every year, those things make a real difference in reducing non-medical exemption rates. And there's an opportunity there to say perhaps those firmly held views are not as firmly held as one led to believe, and that can be a middle ground that can do a lot of good. And so we have a lot of research to say that increasing those burdens can help reduce these non-medical exemptions and improve vaccination rates.
Well, it's still, I mean, I think, Bill, the increase from that 70% to 90 or wherever it is generally is not, it's not that that 20% group is anti-vaccine. They're people who just couldn't be bothered for one reason or another, right? Or, they had other things going on, they just,
Parents with 17 children,
Right.
I don't know,
Yeah, right.
I'm being facetious, but
Right.
somehow they couldn't get themselves organized. People live hectic and sometimes disorganized lives to get their children vaccinated and brought into the doctor on a sufficiently
Right,
regular
right.
basis. But once you put that hurdle out there, they managed to reprioritize their lives, so they got their children vaccinated and protected, and the disease was eliminated.
So what's the best structure now, if you're going to allow exemptions, non-medical exemptions, just make them jump through as many hoops as possible? I mean, what state has done that the best? Any?
New York,
New York?
right?
Well, New York has a very stringent religious exemption. It's not just procedural in New York. The exemption itself, so New York is the only state that has a strong sincerity requirement in its religious exemption. You have to actually show sincerity, and you may be grilled and refused if they think your opposition to vaccine isn't sincerely religious, which kind of, in my view, discriminates in favor of people with lawyers or people who are better at presenting an argument.
Faking sincerity.
Yes.
Not always, actually.
Exactly.
I had the experience where even though they've really fought vigorously against the school ended up saying, "Nah, we don't believe you. Even
Yeah.
though you came with all this stuff, we still don't believe you. You have to get your child vaccinated."
I think the biggest...
My kind of
yeah.
school.
Yeah.
Yes. Yeah,
Public high school.
I think the biggest change I've seen in recent years, and correct me if you know of any more, is Michigan states did something in the rules, not by the law, that was simple but seems to be very effective. In the rules they said, you want to get a personal belief exemption, you can get it for any reason. We're not changing that. You need to go to the Department of Health, get an explanation about the risk or benefit, they'll sign that they explain it to you, and then you can have your exemption. So the substance is the same, you can get an exemption for any reason. But this procedural hurdle led to a pretty substantial jump in the immunization rate. It's now there's a law proposed to change it.
And this risks getting too far into the weeds of sort of civics, but in many states, new vaccines can be added to the requirements. New procedural burdens or administrative things can be added by the State Department of Health. It doesn't need a bill passed through both houses of the state legislature and signed by the governor. And there's a lot more opportunity there for measures at the state level to be proactive without the challenges of legislation.
Philosophically, do you all, well, I'm really nervous about using philosophically, but no, I mean, is there any reason that mandates for adolescent vaccines should be any different than those for infants or little kids?
Well, I believe that if mandates work, school requirements work, use them. It doesn't matter the age. And frankly, as we start to look at immunization across the lifespan, I think it's something to look at for all people, because in general, it is easier not to do something. I mean, we all have busy lives.
Sure.
I think that we've got to figure out a way to make it work across the lifespan. Absolutely important for adolescents.
Let me ask one last question, and then I'll throw it up for the audience. In the current environment, we mentioned this a little earlier, but just in terms of what you all are encountering, I know there's a lot of concern about vaccines becoming a partisan issue. To what extent do you all think that that's happening?
I agree with what you said in your opening. I think vaccines are subject to false information on both the right and left. That's my sense of it. But I'm curious about.
So the left has to keep up its part in providing false information. Else it could become a partisan issue. I'm sorry.
I mean, I personally see the whole anti-vax thing as like just it's being personified by this whole fake news thing now. I mean, it's like fake science. Like, here are the facts. Oh, but I choose not to believe them because, as it was pointed out earlier, it doesn't fit with my belief system. So I will choose to ignore it and go with the facts that fit with what I believe in. And I find that just so dangerous, and that it's really kind of become like the norm now, after the current election. And I think it's really giving validity and purpose to people who are anti-vaccine. They have a voice and they have something they can, almost fall back on now. That it's acceptable to call it fake news, fake science, whatever you want to call it.
Yeah, I think it's actually a sort of more of a study of extremism. But there was actually a recent study published regarding HPV vaccine that showed that blue states have higher immunization rates than red states. So I think it is political, but probably more in the extreme side than not, than blue or red.
Yeah.
I think so. There's a lot of efforts, I think, is made and should be made to make sure that this doesn't become partisan.
That's right.
There's an effort on the part of anti-vaccine activists to channel the language of choice and appeal to the right idea of freedom of choice, etc. And it's sometimes more effective than others. So we do see some partisanship in terms of voting patterns in state and politicians that bring pro-mandates laws being more Democrat than not. But that's not far from universal, and I think we should continue to work to make sure that it's more bipartisan than partisan.
Maybe you should be lobbying all these doctors in Congress, because they're all Republicans, right? So almost all. Like
They're not pediatricians.
14 out of 16, no, they're not. But I think most of the physicians in Congress are Republicans. So.
And I think most of them are not anti-vaccine.
Well, that's right. That's what I mean. But they
Yeah.
need to be activated to,
They need to speak up.
spread this. They need to speak up.
Yes.
Yeah.
Okay. Well, I think we should take some questions from the audience on any subject related to vaccines.
Yeah, question. Test. Do you think students or parents who do not want to vaccinate their kids, should those kids be homeschooled or allowed to attend public schools at that risk?
I'll start off. I worry about, I have concerns about potential long-term effects of these policies, and I worry about homeschooling being seen as a viable option for anyone who doesn't want to comply with state requirements, because we know that homeschooling is not an option available to everyone. So I think if we want to make a strong argument for ironclad requirements, we shouldn't fall back on, well, if you don't like it, you can just homeschool your kids, because we know that's not an option that many families can choose to do. So I'm concerned about that. So I'm not dodging your question, but the homeschooling as sort of a viable pathway to allay concerns about ironclad requirements is something I think we need to think more carefully about and see how it actually plays out.
And I think another way to look at it is, who's really at risk here? If all the kids in school were required to be vaccinated and they're in school, now you're sending an unvaccinated kid, who's going to get sick? The unvaccinated kid is actually at higher risk of getting something from all the other kids that he's going to be exposed to in gym or in classes, and that's the kid who potentially really is going to have some serious diseases occur. Yeah, you might catch a few kids who maybe the vaccine didn't take, whatever, but really the high-risk kid is the one who wasn't vaccinated.
Hi, so I'm from Connecticut, and in the state of Connecticut for college entrance, you have to be vaccinated with meningococcal in order to be a resident on campus, but not for commuters. So I also work at one of these universities, and we have had a few students in recent years who've used the religious exemption that we have who want to live on campus. So I'm also curious as to, I heard a couple things going on in Texas and in terms of registries of parents that are refusing to vaccinate their children or having access to that, or what if, let's say, you have these students living on campus and they're living with people who might be immune compromised, anything like that. In terms of rights or legislation or things of that nature, would people have access to that? If you were immune compromised and you're living with somebody who is choosing to not vaccinate themselves, but the school can't refuse them, is that information available, or are we moving towards any of those directions in terms of parents having to register if they don't want to vaccinate their kids?
Can I ask you a quick question? What religion did they say is telling them they shouldn't get a meningococcal vaccine when they go to college?
So I probably shouldn't say this, but they actually said that they are just going to get a minister to sign the form. So, yeah.
And that's one of the problems with the religious exemptions. They're more often than not used without a real religious reason. But you're asking, is there a way for me to know whether I'm at risk in that situation? And the answer is, some states have at this K through 12 level information school by school about the rates of immunization, but no state has actual naming of who is not immunized, and not in the school level, not at the college level. And I think that's the right policy personally, because I would be worried about targeting of children and families who aren't immunized. That's probably more of a concern at the school level. However, information, if you know rates, that's one step in the right direction. And maybe one way to handle it is to get information about how many people in your college or how many people in a dorm have religious exemptions, so that if you know the dorm has X people that are exempt, you can say, I have a medical reason not to be in this dorm. So maybe that's one way to go there.
Yeah, those students are probably protected by FERPA, which is the educational equivalent to HIPAA, which is the privacy law that it requires us all to maintain confidentiality. In the educational realm, even medical records in an educational setting are protected by FERPA. So I don't think it would be possible to have individual names.
So there's legislative ways around that, but they're a little complicated. Yes. You'd have to pass laws accordingly.
Are you at a private college or a public college? State University. I was going to say, because most schools have their own archaic ways, so it'd be basically like the hurdles that are put in front of those exemptions. I mean, colleges, I remember for college, I got a whole list of things that I needed to have done and stuff, and theoretically, if they opt out, then I'm sure additional things can be written in, because you're making a choice to attend that college, and if the college is going to accept you, I guess they could put in whatever rules. I mean, state would probably be somewhat different. Private, you can write whatever you want.
Thank you. Great panel so far. And you all commented earlier that a curriculum is needed for healthcare providers. If you had your ideal, what would it be? And maybe from the pediatric, adolescent, and adult side, please.
I'll actually start. I'll start from the parent side. So we talk to a lot of parents about why they don't immunize and what happens in that conversation and why was that conversation non-persuasive. And the number one reason that we hear is that they felt that their healthcare provider wasn't taking their concerns seriously and didn't engage in a dialogue where the parent felt like an equal participant in their child's health care. So we actually created a curriculum that's on our website and free, where we outline very basic communication 101 type steps, where we think that the parent is you're more likely to have a better outcome. So those steps, very briefly, are we encourage healthcare providers, when they encounter a patient, a mom or dad who's vaccine hesitant, to find some topic on which they can agree. So if the parent is coming in saying, I heard Jenny McCarthy on television, and she said that the kids get too many vaccines too soon. You can say something like, yes, kids today get many more vaccines than when we were kids, so I can understand why you have concerns. And just something very basic like that. It says to the parent, I recognize your right to ask questions. We're going to have a conversation where we are equals. Now I'm going to give you the information. And then we're going to make a decision, and I'm going to tell you as a healthcare provider what the parameters of my practice are and encourage you to be immunized. But I think a lot of times what parents say is they raise their concerns and the doctors immediately jump to the science. The science says this, the science says that. And parents are, they immediately get defensive, and they, as Dr. Schaffner was saying, they double down on their anti-vaccine position. So we find that just taking a few extra minutes to address these concerns that the parents have raised leads to greater uptake.
Well, what I was going to say is everyone up here works a lot with vaccines. I became more involved in vaccines as a pediatrician back in 2004. But let me just say, and this is not meant to be insulting for physicians, but there's a lot of medical knowledge to know. Vaccines are not covered very well. I'm not sure how many people who are not fully involved in immunizing truly even understand what's involved in the development of a vaccine, in the implementation of a recommendation, how a recommendation comes to be, how a conjugate vaccine is different from a polysaccharide vaccine. We aren't taught that, or at least we weren't back when I was in medical school. And so this comes back to what I think providers actually need to learn the basics of vaccinology, which are taught in some wonderful courses for providers, actually. NFID actually has a wonderful one that I think could be adjusted for all providers. They need to understand what the safety information is and how it's generated, because I think a lot of providers will say, oh, I heard on the news that someone had a bad reaction to that vaccine, so I'm not giving it to my patients. Those providers don't understand how that information is generated. And then having a very important piece of the curriculum dedicated to how to talk with parents about it. Parents who are scared, just probably asking, again, for more information. Because again, only about 1% to 2% probably are truly anti-vaccine.
I think an important part of the curriculum would have to be role-playing. I absolutely agree with but it can't be a curriculum because you're just getting knowledge. You have to implement it, you have to see what it's like. So I think you would have to have some, sessions where you're actually, dealing with somebody who's role-playing a parent, or, the final would be actually engaging such a parent, because until you actually have to do it, you can have all this knowledge you want, and you still need those communication skills, and I think Alison really hit it on the head. You need communication 101.
Mary Beth, I think.
Well, just
Hold
one-
on. So I think
hold
she
on.
wanted to comment on this.
Oh,
Didn't you, Mary Beth?
Yes.
oh, okay, sorry.
I usually don't show mic. I'm used to talking to people. But I can't stress enough to you, Alison's case method, we've taught that to the nurses. We had a whole program that we did through the ANA and with Every Child by Two. They were the producers, and I was fortunate enough to be asked to be part of that, and it still exists. I mean, the vaccines themselves have to be updated, like what the new schedules are, but all those basic communication skills and role playing. And the nurses in Suffolk County, the nursing schools in Suffolk County and Nassau County made that part of their school curriculum. And I got phone calls and emails from nursing students who said, we didn't even know what a vaccine was until we saw that video. So, there's all kinds of things that you can do. I mean, it still kills me that my health department would never let me do a real study to validate Alison's case method, but I'm telling you, it works. It's that proactive, it's learning those communication skills, it's the motivational interviewing, which is exactly what Alison was talking about, that we need to teach everybody, nurses, physicians, parents. I mean, that's a big thing. There was another study that came out that said parents are much more likely to vaccinate if another parent says, yeah, I vaccinated my children. My daughter-in-law is an attorney, and she is a wild woman. She won't let anybody near her children that she knows is not vaccinated. But what she does is she tells her, my children are vaccinated, and I think it's important for your children to be vaccinated. And I said, oh, I wish I could get some data to find out how many moms you changed their minds. So, it's all about getting that word out and how we say things.
So two quick things about educational programs. One will be a surprise to you, and the other is a bit radical. The surprise is, think about all the healthcare professionals you know in all their various disciplines. Which group has the most thorough and comprehensive vaccine training? Pharmacists. They absolutely have a very structured vaccine curriculum, so that's a surprise. The radical idea is, think back for a moment. One of the big problems is that young mothers today don't know about the diseases and don't know about vaccines. Look at your own middle school and high school health curriculum. We did a survey, not really, but we looked at several. The attention devoted to vaccines is very uncertain, it's incomplete, and almost none of the vaccine preventable diseases are taught. I think we need an introduction of vaccine-related material into the health curricula of middle and high schools. Then, at least, when those people become parents, young parents, they'll get a booster dose from their pediatrician and obstetrician.
How do you deal with an adult who doesn't want a flu vaccine? And then I can tell you what I've done, and I've never had anyone turn it down. But Just curious
Well,
what you did.
I'm very interested to know how you
I'll
have
tell you
no one
afterwards,
turn it
yeah.
down but I use the insistence method. We talk about your vaccine and it's time for your vaccine, just the way we insist on antihypertensive treatment and treatment for diabetes. So we don't offer it, we insist upon it, as I mentioned before. But I'm curious.
So, and of course, these are usually people who are not, you know, in the office, you know, the people you mingle with, right? And they're talking about vaccines or not having. So I've explained to them about memory, immunological memory. And the simple way is saying, look, if you don't do this now while you're young and able to respond, when you get older, and of course that always changes how old I get, but you're going to be in trouble because you're not going to respond to the vaccine the way you need. So you're building it up now. And then you say, gee, no one's ever said it that way. And then I've had no one who said no, they wouldn't do it.
Like for a DTP, a
What?
DTaP, or a, does that work?
No, I'm just talking really with flu, because it comes up and they say, I don't want it, I'll weather it, I'm tough, you know, so when I explain it that way, you know, if you really want to get tough, there's a book by the Immune Deficiency Foundation, you know, about T cells and B cells and that they use for kids who are undergoing transplants or immune deficiencies. And it just explains what each cell does.
But so you're saying be kind to your future self.
Be kind to, yeah.
That's a nice
I will use those words next time, but.
The writer.
Additional questions from the audience? Well,
Can I ask Amy a question?
oh, please, yeah, you guys take it away.
Men B, I'm interested. So we were talking about recommendations and mandates, and particularly on the recommendation front. Talk about the challenges that the current guidance regarding meningococcal B vaccines are creating for parents and providers, and trying to make sense of how that can fit into adolescent vaccines, if you would.
So Men B is permissive, so it's considered to be optional. It's not something I can say is routinely recommended for everyone. But I do think that that vaccine, as with all vaccines, the uptake depends a lot on how it's presented. So I can only describe how I present it. I can tell you that a lot of providers ask me, are you offering it to your patients, and should I be offering it to my patients? And my response is yes, and absolutely yes. But the way I talk about it is that while disease rates are low, if you get the disease, it's 100% that you have the disease, and it's a dangerous disease. I recommend, because it's safe and we know it's effective, and I'm a vaccine advocate, and I believe in primary prevention, preventing something before you get it, because I can't do anything once you've got it. I believe in getting the vaccine. That's from an individual doctor-patient. That's not the public health perspective. But my job as a provider is to treat each individual patient that I encounter. I can tell you from a personal perspective, I gave it to my child. And I can tell you that when you are out of control and your child is 6 hours away and he gets his first fever in college, all I could do was thank goodness that I knew that I had done everything I could to immunize him against the worst stuff. That's my job as a parent. And that I could breathe easily, that it hopefully wasn't one of the worst things and was hopefully one of the minor things. And that's what I tell patients and parents. When your child is 8 hours away, you just have to hope you protected them against everything you can.
I mean, it's a permissive recommendation, but permissive means that you have to get permission. To get permission, you have to talk about it. So the provider is obliged to bring it up if it's, because you have to find out, do they want it or not? And to know if they want it or not, you have to discuss it. And so I think that's the opportunity where you use that, you know, your skills and your communication to tell them, this is a terrible disease, this is exactly what happens to it, and by the way, there's a vaccine for it. You can opt in, you can opt out. And again, if you present in that way, I don't think many people would say no.
We're also really working hard, a number of us are working hard to promote a 16-year-old immunization platform. And there are 2 vaccines that you can get at 16, the booster for the Men ACWY, and then the permissive or optional Men B. And immunization platforms serve as a reminder to providers, parents, kids, this is time to start thinking about vaccines again. Let's catch up on anything and get you whatever else you need. Only about half of the cases of meningococcal disease actually happen on college campuses. It's not, so it should be offered to everyone, not just, I didn't want to make it seem since my kid went away, you could still get it when you're home. So I think that will hopefully take off and also help support remembering to offer those vaccines to everyone. Thank you for asking the question.
I just have one more quick question. Do you think our foundation vaccinates all 6th graders with the ACWY vaccine? When we revaccinate when they're seniors in high school, should it be the B vaccine, or does it make a difference? Or what is your opinion?
So you need to boost. So you get the ACWY vaccine initially, and then you have to boost again. You would need to boost again, whatever, 5 years or so before they go to college, around 16 to 18 years. And so the question, in terms of meningococcal serogroup B, it's Bill and I are on the meningococcal working group to the CDC. So the struggle with Men B, when we say it's a permissive recommendation, of course it's permitted, it's licensed. So, in some ways we punted. I think the reason is the epidemiology has changed over the last, say, 15 years or so, where there's been a decline in meningococcal serogroup B disease without a vaccine. So that's number one. Number two, it's not a conjugate polysaccharide vaccine, it's a protein-based vaccine. Therefore, it's not going to cover all serotypes. So breadth of serotypes has also been an issue, and duration of immunity is an issue. And I think that's why the permissive recommendation is going to generate more data, and we'll see what we see. But if you're asking me what's the best way to protect yourself against Men B, it's going to be to get a booster dose. You're going to need to get a first dose and then a second dose probably 5 years later. I think that's probably the best way to protect. Although interesting, most Men B disease actually occurs in the baby. So if you really wanted to know an excellent strategy for men, I actually wrote a Daily Beast op-ed about this. I write this weekly piece, and I talked about maternal immunization. I think maternal immunization for meningococcus would be of value because it could protect you the first few months of life.
Well, yeah, let's talk about that for a minute. An adult platform, how realistic sort of is that beyond get your flu shot?
Well, I think
actually what I meant to ask is for a maternal
immunization. The Advisory Committee on Immunization Practices is getting more and more involved in adult immunization and promoting it. We do need platforms, but for sure, I think now there are already 2 vaccinations that are recommended for women in pregnancy. One, influenza during influenza vaccination season, and the other, Tdap, tetanus, diphtheria, acellular pertussis, that's the whooping cough vaccine. And so women should get those vaccines during pregnancy, and there are now others under investigation. One is Meninge B, and another one is called Group B strep.
Right. And RSV, so, respiratory syncytial virus.
And RSV, thank you.
But we don't get it. It's about 50% of women get the influenza vaccine that they're recommended to receive. Only, at least that New England Journal of Medicine paper looking at 16 states and New York City found only about 10% get the whooping cough vaccine. There's about 20 to 25 children every year that die of whooping cough. When they die, they're invariably less than 3 months of age. So an active immunization schedule isn't going to work. The only thing that's going to work to protect them is really to immunize the mother, and only 10% of mothers get that vaccine. So, Walt Ornstein says there's a difference between vaccination and vaccines. If you don't get them, they don't work.
And from my personal experience, we need to reach out to our colleagues who are the obstetricians, because they're the ones who just aren't doing it. They hear the recommendation, but they just don't follow through. And I hear that from the mothers of my patients all the time. It was never offered, never discussed. They never heard about it until after the baby's born.
And you probably want to reach out to them generally about vaccines, because they probably should start having those conversations.
Yeah. Right. Anyone else? Further comments, things I didn't ask, things that weren't discussed that we should be hammering in?
Well, if you're closing up, Arthur,
yes.
I want to look into the camera, have everybody look into the camera. Lynn Bozoff, you're watching us. We're thinking of you. We wish you were here, and get better soon.
Yes, please get better soon.
Thank you all for coming.
Thank you.